All right, I think without further ado, we can start with preliminaries, and then whoever will be joining will find us along the way. Good evening once more. My name is Dr. Wesley Banda. I'm the chairperson for the Public Health Board of the Zambia Medical Association. So, on behalf of the Zambia Medical Association Executive Committee, I would like to welcome you all to this evening's webinar on the topic toxicology and clinical management of heavy metal poisoning. And today we'll focus mainly on lead, arsenic, and manganese. So this is a topic that is both clinically relevant and increasingly important in our national discourse in the context of Zambia. As you may all be aware, the economy of Zambia has largely been driven by mining. So it is deeply intertwined with mining and industrial development. And while the development aspect of it is very good, it does not go without damage and dangers to the communities and the population as a whole. The most famous or infamous is the Kawa lead poisoning. But recently, we've had incidences of mine accidents like the failure of the tailings dam that happened on the Copper Belt. Then also a similar incident happened in Luapula province in Mwense. And this puts a risk on not only the water bodies in these areas, but also the human lives around the mining areas. So tonight's webinar is designed to give us some information and know-how on how to recognize and manage these heavy metal poisoning, as well as a step forward into the discussions concerning mining and heavy metals. I'm not alone from the Zambia Medical Association this evening. So before I proceed to introduce the speakers, I'll invite my co-moderator for the webinar, who is the Zambia Medical Association Vice President, Dr. Bright Mackenzie. Dr. Mackenzie.
Thank you so much, Dr. Banda. Am I audible?
Yes, you are.
Yeah, so today is Dr. Banda's show, but I would sincerely love to welcome everyone who's on the call. These are rare topics that most of us usually have problems when they happen. We always want to look towards the physicians, and for some of the people, especially those that were in Wapula, maybe you may only have one physician there, but it's important that there's this webinar to help us at least that when we happen to be in the place where such poisoning is happening, at least we can do the first steps before we refer to the physician. So I would encourage each one of us to pay particular attention and also to take such webinars very seriously, because some of our friends might not have an opportunity to actually learn about these things. So let's take this opportunity and embrace it with both hands and ensure that at least at the end of it, we go with something that will help us save the lives of Zambians and other societies at large. Thank you, Dr. Banda. You can take it up.
Thank you, Dr. Mackenzie, for those remarks. So our speakers for this evening, first we have Dr. Sumbukeni Francis Kawa. He's a clinical pathologist with specialization in hematology, microbiology, and clinical chemistry, who also has an interest in medical toxicology as well. His main focus has been in the field of hematology, with particular interest in hematological malignancies, anemia, including sickle cell anemia, bleeding and clotting disorders. He is involved in diagnostics
physical inspection
and clinical care.
Ms. Luhanga says updates will continue to be provided as more data is received throughout the inspection. The inspection of the provisional register of voters is currently underway ahead of the August 2026.
Dr. Somwe, sir, please mute your mic. Thank you. Apologies for that. So I was giving a brief on Dr. Mukeni Kawa. So his main area of focus has been the field of hematology, with particular interest in hematological malignancies, anemias, including sickle cell anemia, bleeding and clotting disorders. He is involved in diagnostics and clinical care of hematological patients, and also in teaching the next generation of medical doctors and scientists. He is also a specialist in poison information and one of the members of staff in the Zambia Poison Information Service, providing poisoning advice to clinicians and the general public. Dr. Kawa, good evening. You may just greet the attendees.
Good evening. Thanks, Dr. Banda, for that introduction.
Thank you. Then next we have Mr. Nicholas Brooke, who is a toxicologist with over 15 years experience in both poison centers and chemical public health fields, and is currently employed by the Radiation, Chemical and Environmental Hazards at the UK Health Security Agency. He is currently leading on projects to strengthen chemical capacity in Zambia and Nigeria, and works closely with the World Health Organization on the African Network of Poison Control Centers. He is one of the lead authors of the updated WHO guidelines for establishing a poison center, and is involved in establishing a European partnership on poison centers. Previously, Mr. Brooke has been involved in a wide range of UK chemical incidents, including the Grenfell fire and the Novichok nerve agent poisoning. Mr. Brooke, you're welcome. You may just greet the attendees for the webinar.
Thank you very much for the very kind introduction, Dr. Banda. It's a pleasure to present to you guys today in partnership with Dr. Kawa and the Zambia Poison Service. Thank you very much.
Thank you so much. And finally, on the discussants panel, we're going to have Talon Parnell, who will be with us as well. He's a toxicologist with over 10 years experience in the UK National Poisons Information Service, handling over 20,000 poison inquiries during his time. He currently works in the UK Health Security Agency, where his primary focus is on developing poison centers and strengthening chemical capacity in medical toxicology, and was a contributor to the 2021 WHO guidelines for establishing a poison center. Talon, you may just go ahead and greet the attendees for the webinar.
Thanks, Dr. Banda. It's a great pleasure to be here with you all today, and I'm hopeful that we'll be able to share some of our experience in poisoning with you. So thank you very much.
Thank you. So I'll now hand over to Dr. Kawa to take over for the next segment of this webinar. And we invite people to take note and prepare questions. You may post your questions in the chat box, or you'll be given a chance to ask them verbally at the end of the presentation. Thank you. Dr. Kawa.
Thank you, Dr. Banda, and greetings again to everyone. So, as already mentioned, we're basically talking about three heavy metals, and mostly on a clinical side, but also a public health side. We recognized that we do have clinicians who are on the day-to-day basis of seeing patients, and then we have a good number who are in public health and ensuring that they prevent hazards from affecting us. So for those three elements, each one of the three of us will present one, and I'm not sure if I'm going first.
Yes, Dr. Kawa, if you do the first couple of slides on ZPIC, and then we can do a bit on UKHSA and go from there.
All right. So just to take advantage of this audience, this distinguished audience, we want to create awareness of the Zambia Poison Information Center. So this service is available to our clinicians for advice on management of cases of poisoning. So you can go to the next slide, please. I think we can skip this. So as already mentioned, yeah, it's and then of course for the reason why this is important is that Zambia has signed up to the international health regulations, and one of the core capacities is for us to have an availability of a poison information center and also access to toxicology lab services. Next. So we're using a mobile line, but as time goes, we'll have a toll-free number which you can dial into at no cost, and we'll make sure it's widely shared. So this little poster you're seeing is something that we've printed out and distributed to some of the hospitals within Lusaka, and hopefully you can distribute wider as well, just to ensure that this service reaches everyone who requires it. Okay, so it's currently being trialed within the main hospitals in Lusaka. We are getting calls here and there, and it's good. We know most clinicians will know what to do with some cases, but there are those cases where some extra help is required, and that's where we come in. We have access to databases which have peer-reviewed, up-to-date information on management of poison cases. So, and these are updated regularly. So we always have up-to-date information. Okay, we can proceed to the next. Yeah, I think we can leave this one. The most important is that the panel here is aware that the service is available, and please take note of that contact so that when you do need this service, it's there for you. At the moment, just to emphasize, it's 8 to 17, so we are not 24 hours yet. So, and we know emergencies mostly tend to come in the small hours of the night. So eventually we'll be able to go 24 hours, but for now, 8 to 17. So please bear with us. Okay.
Thank you very much, Dr. Kawa, for the excellent summary. I'm just going to do a couple of slides on what we do before going back to passing over to Talon for lead. So basically, with the chemical and poisons team in UKHSA, as a bit of background, we're a WHO collaboration centre for the management of chemical exposures. And, we do a lot of work with the World Health Organization for planning and preparedness, response to incidents, recovery from incidents, and especially chemical incidents of public health concern, especially those that may cross borders under the IHR regulations, as Dr. Kawa said. So we work on developing a lot of guidance and tools. It's already mentioned in the intros, Talon and I's involvement in the WHO guidelines for establishing poison centres. As part of that, we also contribute to the development and delivery of training materials and programs. Myself and Talon are both part of this WHO Collaborating Center, and also Mario's on the line today. Some of you on the call may have gone to the chemical prioritization workshop that's going on at the Holiday Inn in Zambia this week. So just to say, it's all part of the work we're delivering. Go to the next slide, Talon. Yes. And just to say that, you know, we've been working now with Dr. Kawa and other stakeholders such as ZMPHI in Zambia for a number of years now, strengthening chemical events. But a bit of background to the project for those who haven't heard about it before. It's called the UKHSA IHR Strengthening Project. And we work in a wide variety of expert technical areas. As you can see in the box in the middle, everything from biosafety and security to points of entry, One Health, workforce capacity building. Our expertise obviously comes under chemical hazards and poisoning. So that includes, you know, doing work on surveillance, prioritizing chemicals, and also, you know, working with Dr. Kawa to support him to establish his poison center. Important to say that the way we work is that we work through peer support and mentoring. We're very partner-led, and we're very focused on creating sustainable outputs from our projects so that, you know, if our funding stops or once our project is finished, we can, we leave a sustainable, you know, project in place or systems in place in Zambia and other target countries. And there's a barcode you can click on in the bottom right corner and a link if you want to learn more about the AHR project. I know our ZMPHI colleagues online are already very well aware of us, but I'm conscious that not all the clinicians on the call will be. Thank you. I think I'm passing over to Talon now. Thank you.
That's right. Many thanks, Nick, for passing over. So as introduced, my name is Talon. It's a pleasure to be here today. I'm going to kick off by talking about lead. So lead is, to me, one of the most fascinating poisons. It's also potentially one of the poisons responsible for the highest burden of disease worldwide. So lead is considered a heavy metal, which effectively means they're a high density, stable, and non-biodegradable element that can accumulate in the environment and in biological tissue. So this can pose a problem if it accumulates in biological tissues. And we'll talk about how that accumulates in humans and how it can cause toxicity a bit later on. It's a non-threshold toxin. So if any of you are familiar with some of the principles of toxicology, we separate chemicals and poisons into effectively two separate categories. You can either have a threshold toxin with which there is an established dose which you need to exceed in order to be harmful. And you have non-threshold toxins where there is effectively no safe dose of a chemical or poison. And that's the case for lead. So there is no safe dose of lead. If you have any amount in your body, then we know that this is going to create some level, probably some subclinical effects on a person. So it's incredibly persistent and it's available globally. And we've got this problem where any amount is potentially dangerous. So a bit of a problem. It's got various sources of exposure, and we're going to go into that in a bit more detail in the coming slides. We're going to separate them out into occupational exposures and non-occupational exposures. And the reason we're going to separate them out like this is because the routes of exposure are quite different and they can change. I've got a picture here of Elizabeth I, and it's relevant because Elizabeth I used makeup to whiten her face, which contained lead. This unfortunately was thought to be a cause or a contribution to the reason for her death. So this has been used, lead has been used for hundreds of years, especially in plumbing, which is where we get the term plumbum, which is actually where the symbol on the periodic table, Pb, gets its name. So this is a historical basis for lead. This is a chemical that's been around for a long time, and as we know, is very persistent. So we'll kick off with talking with some occupational sources of exposure. One of the biggest, I suppose, sources of exposure is lead paint. So lead paint has been around for quite a long time, and in recent years it's been started to be phased out. So in sort of the 1960s, some countries started to phase out lead paint because it was acknowledged it was causing potentially toxicity or subclinical toxicity, as we talked about. Another one is lead shot for firearms. So I've got a picture here of indoor ranges. And we actually did, there was actually an incident in the UK relatively recently when numerous people were affected due to lead from a firing range. So this is a potential source of exposure, which may be occupational. Other ways you may get exposed are via sanding, blasting, or burning, or abrading, so abrasion of painted surfaces. This is, I suppose, occupational, but it can also occur in the home as well. If you're doing some DIY renovations and you're not wearing the appropriate personal protective equipment, you can get exposure to lead. And the last one has been battery manufacturing. And what I'm going to try and do now is play a video for you. And if you have any problems with hearing the sound, please do let me know. But this is something I stumbled across just last week, actually, regarding lead and car batteries in Africa.
This is Freeman. He has a blood lead level of 28.5, which is more than 5 times the level widely considered to be lead poisoning. And it's all because he lives among some of the most lead-polluting factories in Nigeria. I'm a reporter at the examination, and for the past year or so I've been working with the New York Times on understanding how lead recycling for car batteries in the United States is leaving an entire community exposed to one of the most dangerous illnesses on the planet. I went to Agijo, the lead recycling capital of Africa. We commissioned blood tests on 70 people living and working near these factories. Overall, 7 out of 10 of them had levels of lead poisoning that the World Health Organization considers to be dangerous. More than half of the children tested had levels of lead in their blood associated with lifelong brain damage. One of those children was Freeman, who had the highest level of lead in his blood of any child.
Where do you feel the pain?
Freeman has body pains and aches, a distended belly, trouble sleeping, and also seizures. Now, all of those symptoms are commonly associated with lead poisoning. The lead recycling process can be broken down into 3 main jobs. First are the pickers. They pick up used car batteries one by one and drop them off sometimes by the hundreds each day at the breakers. Breakers are men with machetes that open the battery cases, they drain it of sulfuric acid, and then send the batteries to the recyclers or smelters. The smelters break down the batteries further, and then they put the lead into blazing hot furnaces, where it's melted down and ultimately sent to battery makers to use to make new batteries. The lead rises from these smelters. It's clear that the community of Agijo is being poisoned by lead, largely inhaled from emissions from lead recycling factories. Everyone we spoke to in Agijo who works inside these factories had health complaints of some kind. They spoke to us about how they would cough up black dust, or how they'd spit out what they called black salt. We spoke to people who knew that what they were doing was risky, but who needed the money.
I make my living there.
Shortly after the government of Nigeria received information about the blood testing that had taken place in Agijo, the government suspended the operations of several of these smelters. But about 1 week later, the factories were operating again. The Nigerian government told us that it had allowed some of these factories to open again on the condition that they make improvements and reduce some of the pollution. But according to a document seen by the Times, those commitments were much vaguer. We saw a commitment by these factories to improve certain technologies within 2 to 3 years.
The recycling plants that responded to our questions denied wrongdoing, but said they're making improvements.
For the people of Agijo, this is a public health crisis that has been going on for many, many years, and as our reporting shows, is not likely to stop anytime soon.
Okay, hopefully that was an interesting video. I found it quite eye-opening, and I think it raises the awareness of lead poisoning quite adequately, actually. So lead poisoning in this instance was, being driven occupationally by people breaking down batteries, but realistically, it was the general public in the surrounding area being primarily affected. So lead poisoning is a problem globally, and I think the video highlighted that it's a public health problem. So not all poisons are public health poisons, but lead very much is one of those. So effectively, when we're talking about occupational routes of exposure, it's most commonly inhalation. So that's where the lead from these batteries, how it was being distributed, was particulate matter inhalation by residents in the sort of surrounding vicinity. So occupationally, we most often see this due to inadequate personal protective equipment or even poor hand hygiene, which is one of the few cases of ingestion by occupational exposures. So here I've got a chap who's eating his sandwiches. He may have actually been handling lead in his job and did not wash his hands in between. And he's actually intaking a reasonable amount of lead, like a reasonable dose that, as we know, any dose is potentially harmful. So what about some non-occupational sources of exposure? Well, what we found is that typically traditional remedies and cosmetics or herbal medicines are very commonly contaminated with lead. And this is potentially because we know that lead exists in the soil and it doesn't biodegrade easily. So any herbal medicines that have been, have been grown and then put into a formulation for consumption, that carries a risk of lead poisoning. Another way is via pica, which is a behavior associated with autistic spectrum disorder, where lead-containing paint peeled from external surfaces and the soil may be ingested by children. And this is something we see very common in the UK, and I've no doubt it's very common globally as well. Recently, we conducted a very preliminary literature review of poisoning in Zambia. And lead poisoning, particularly in the Kabwe region, as Dr. Banda mentioned earlier, was the most common type of poisoning identified in this literature. So we know it's a very pressing and very present problem in Zambia, especially for the general population. Some other routes of exposure that may not necessarily be as straightforward are actually from homemade or imported ceramics. So certain types of clay are known to be high in lead, and hence homemade clay, you might expect dermal or ingestion to be routes of exposure. And glazes are often used on ceramics to prevent direct contact with potentially lead-containing ceramic surfaces. So that's one way of potentially getting exposed. Another couple of ways are imported toys, and actually snooker chalk is used. It does actually contain some lead, and water, of course. So I've included a picture of a well here, and natural water sources are a very prominent method of lead exposure as well. So now we talked about sources and routes, let's talk a little about about toxicokinetics. So effectively, in terms of absorption, there's quite a variable amount of lead absorbed. And what we know is that children actually absorb lead at a much greater rate than adults. So children are particularly vulnerable, which makes this quite problematic to deal with. But somewhere between 10 and 50% tends to be absorbed. Once it's absorbed, it's then distributed in red blood cells bound to delta amino lavulanic acid dehydratase, or ALAD. Lead is distributed to soft tissues, particularly the liver and kidney and the bone. And we're going to talk about next what these compartments look like. So compartment 1 is the blood, as we just said. So this consists of ALAD-bound lead in the red blood cells and free lead in the plasma. This only makes up 1% of the total body burden of lead. The biological half-life in the blood is about 35 days, and this is a lot longer than many chemicals and poisons you may have encountered thus far. As we know, lead does not biodegrade very easily, and it's very persistent, and the same goes for inside the body as well. Compartment 2 is in the soft tissues, where it makes up about 0.5% of the body burden. The half-life is similar to that in the vascular system, about 40 days. But the real problem with lead is in compartment 3. This is where storage in the bone is most prevalent. So 98.5% of the body burden of lead will be stored in the bone. And this can have a huge half-life, potentially something along the lines of 10 to 15 years. So as you can expect, if you've been exposed to lead in a significant quantity, you may have bone deposition, and it may take a very, very long time indeed, potentially decades, for this to be lowered to a quantity where you would not expect any further effects. But again, there may be subclinical effects associated. So how does it work? Well, lead complexes with important functional groups, so carboxylic acid groups, amine groups, thiol groups, and they disrupt functions of key enzymes fundamentally. So it can substitute for calcium and zinc as well, which makes it a problem because this actually has the potential for widespread chemical interactions at cell membranes and within intracellular organelles as well. So there's two main mechanisms here that we have to think about when considering lead toxicity. So here is a diagram showing how you might expect lead to interface with some of the biological systems we've talked about. So you can see at the top here, lead interfering with alad dehydratase, and the pathways by which it may eventually end up with this negative feedback loop via the heme, as I mentioned then. So this inhibition of heme synthesis is effectively via inhibition of ALAD. So the conversion of ALA to porphobilinogen, or the heme precursor, is blocked by lead, and this leads to an accumulation of ALA, which mimics GABA, so gamma-aminobutyric acid, and stimulates GABA receptors. And this is what causes the primary form of toxicity of lead, which is neurotoxicity. In terms of the disruption of the key enzymes that I mentioned, it inhibits erythrocyte pyrimidine 5 nucleotidase, and that will result in the accumulation of pyrimidine nucleotides in immature red cells and causes membrane disruption. This will lead to a shortened red cell lifespan and something we refer to as basophilic stippling. So on this little diagram here, you can see the presence of numerous basophilic granules dispersed through the cytoplasm of erythrocytes on a peripheral blood smear. As a better image, here is another image of basophilic stippling. As you can see here, these blue dots are those basophilic granules. So this is very typical of lead poisoning and quite a good signal, I would say. So I say it's a good signal, but realistically, if we want to prove lead poisoning, I think blood lead concentrations are quite vital. Lead is quite insidious. It's quite difficult to detect. It doesn't necessarily make its presence known, especially within the realm of subclinical toxicity. So we know that lead causes developmental delay in children. Any amount of lead present in a child may actually impact their IQ scores in later life. We know that it's associated with higher crime rates in lead-affected individuals. So it's a very insidious poison, and really the only way to get any guarantee of diagnosis of poisoning is by getting a blood lead concentration. However, it's not always so simple, and we acknowledge that lead concentrations are not a particularly easy assay to regularly obtain. So there are a few signs you can use in your clinical practice. This is one called Burton's line. So this was described in 1840 by Henry Burton. It's a clinical sign found in patients with chronic lead poisoning. It's a very thin black or blue line, visible just on the line of the gums and at the base of the teeth, as you can see on the arrow here. It's caused by a reaction between circulating lead and sulfur ions produced by your oral bacteria. And this forms deposits of lead sulfide in the gums, which is what you're seeing with this line. Here's a bit of a close-up image. And another image of the base of the teeth here. And one more just showing that that indicative line. So that may be a way you can establish lead poisoning without having an assay, but realistically, a serum blood lead concentration is going to be the most effective way. So what sort of features do we see? Well, typically we would see non-specific gastrointestinal and central nervous system features. So typically these occur once the blood lead concentration is greater than 50 microgram per deciliter. Now, coincidentally, this is actually quite a lot higher than the concentration by which we would attempt to prevent someone from having any further lead exposure, which is around 20 micrograms per deciliter. So by the time you're actually getting symptoms, your lead concentration is reasonably high. But typically tiredness, headaches, abdominal pain, constipation, and anorexia are things that you might expect to see. So these are, again, GI and CNS features that predominate. In sort of higher level concentrations or higher lead exposures, we may expect to see impaired concentration and memory, potentially confusion or coma, and seizures, which is one of the most indicative features of lead toxicity, is this sort of proconvulsant effect. A child who is comatose and seizing, one of the first things I would think of would be potentially lead toxicity. There's also potential for neuropathic effects like wrist and foot drop as well. Renal toxicity is something that's extremely common in lead poisoning also. So you may see a renal tubular dysfunction and hypertension as a result of lead toxicity. Anemia is very, very common as well. So the impairment of heme synthesis, as we talked about, and the shortened red cell lifespan may result in anemia. And what we also know about anemia is that children who are already anemic prior to lead exposure are more likely to be to receive a higher dose of lead when ingested. So anemic patients are at risk before being exposed to lead, but also lead can cause anemia. So what do we do about this? Well, as mentioned before, the first step, if possible, is to do a whole blood lead concentration. As mentioned earlier, even low blood lead concentrations under that 20 microgram per deciliter may still be detrimental to health. So the focus is always on removal of source. So identifying where the child or adult is being exposed to lead and removing them from the source as best as possible. Thereafter, there is actually the option of chelation therapy, which should be considered for patients with blood lead concentrations greater than 50 micrograms per deciliter, which is that range where, as I mentioned, you may see clinical effects, or if they're encephalopathic. So typically, encephalopathy is a lead-derived encephalopathy is a surefire point at which we would consider chelation. The blood lead concentration, if it's over 50, but they're otherwise quite well, we may actually opt to just try and limit source of exposure. But encephalopathy tends to be a point where we would almost certainly try and chelate. So how does it work? So chelation therapy, effectively you have the metal at an in vivo binding site, so lead, for instance, at an in vivo binding site, plus the chelating agent. This will result in the metal chelating agent forming a complex with lead and being renally eliminated. So I suppose one consideration is that we know that renal function can be impacted by lead toxicity. So I suppose optimizing the renal function to enable elimination is another step to consider in this process. So here we have some of the chelating agents. Essentially, in recent times, toxicology tends to prefer two of these chelating agents, which are sodium calcium meditate and DMSA, or Suxima, as it's also known. Of the two of them, sodium calcium meditate requires IV, typically, administration. You can also give it IM, whereas DMSA you can give orally. And this makes it a lot easier to give in children. So Suxima or DMSA tends to be preferred in children, and it also results in less zinc depletion. So these chelating agents do actually bind to blood zinc, iron, and calcium. So this is a consideration when giving these chelating agents. As you also see here, the adverse effect profile is better with Suxima, but it doesn't necessarily mean it's more available, which may be half the problem. I've put a note here down the bottom that dimercaprol was also a chelating agent used in heavy metal toxicity. However, in the past 2 or 3 years, the manufacturer has actually stopped making dimercaprol. So it's unlikely we're going to be able to use that going forward for lead poisoning. So the purpose of chelation is to enhance urine lead excretion, as you'd expect, and to reduce blood lead concentration. But there are some cautions. So chelation therapy actually may result in remobilization of lead from the bones. Remember how we talked about how the blood concentration of lead is only 1% of the total body burden, and the majority is in the bones. So what we've seen is when you chelate a patient's blood lead concentration and it comes down, it will actually spike again. It will come back up as it's remobilized from the bones. So someone with a high lead burden, you may expect a lead concentration that goes down and up as you chelate them. And this actually may result in deterioration. So it may actually happen that a patient seizes once you chelate them. So this is, again, quite a challenging poison to manage. As mentioned before, they also affect zinc, iron, and calcium, so you need to consider supplementation when giving chelation therapy. And there's an expectation in high burden cases for this level to go back up. So really, avoiding further exposure is the priority. I can't emphasize that enough. The total burden of productivity lost from lead is unknown. Most people poisoned are not aware they've been poisoned because it often has subclinical or non-threshold effects. One study estimated the loss of sort of global income or global productivity to be in the realm of $6 trillion in 2019 alone, which may be comparable to some of the biological agents that we see that attain much higher scrutiny and attention. So lead is a big problem globally. I thought it'd be good to do some a very sort of example case just to finish off before I hand over to my colleagues for some of the other heavy metals. So here is an example of a 14-month-old female who presents to the hospital with a 1-month history of abdo pain, irritability, and lethargy. The patient's family doctor became concerned after she failed to achieve some of her developmental milestones, and they suspected to be lead poisoning. So which blood tests would be useful for diagnosis? And I'd be very happy for you to share your answers in the chat. And once I'll give it a minute or so, and then we'll go through the correct answer and proceed. Yeah, as Nick pointed out in the chat, this is not a test. This is just an interactive activity case study. D, very good. Yeah, I completely agree. So the correct answer is D, all of the above. So as we know, blood lead concentration is very good for establishing diagnosis and may give you some idea of severity. But we know that the blood lead concentration isn't a complete picture because most of it is stored in the bones. We know that zinc, calcium, and iron are important because it can deplete these metals in the body. And we know that it can cause renal dysfunction and anemia, hence the bloods from C. So the patient's blood lead concentration returns as 58 micrograms per deciliter. Does the child have a concentration that may indicate chelation therapy? Yes or no? Lots of yeses, lots of A's. That's absolutely perfect. The correct answer is yes. So this is a level where we'd consider chelation therapy. As mentioned before, if a child is frankly encephalopathic, that tends to be where we would go in without much hesitation. But certainly above 50 micrograms per deciliter, we would at least consider chelation therapy. Absolutely right. The third question is, which chelating agents might we use in this circumstance? IV sodium calcium editate, oral DMSA or succimer, or dimercaprol, or all of the above? Some answering B and some answering D. I can see the rationale for both. So I would say the correct answer is all of the above D. And the reason is because you can use all of these agents for chelation. However, those saying B, I acknowledge that I did say that succimer is better in children. So I also agree I would try and use succimer in this case. But in theory, you can use any of these chelating agents. So I'd say that everyone here is correct. A couple more questions before we move on. So question number 4, what needs to be monitored throughout chelation therapy? Got blood lead concentrations, zinc, calcium, iron, or full blood counts, urea electrolytes, or all of the above? Yeah, I think I agree. So this is a rather unanimous answer of D from what I'm seeing in chat. So all of the above. We know that the lead concentration may go up again, and we know that the chelating agent itself can deplete these important metals. And it can also result in renal toxicity itself. So the chelating agent's not to be used without significant caution. And lastly, why might the blood lead concentration increase after chelation? Is it that the chelating agent appears as lead on an assay as a confounder? Is it that there's remobilization of lead from the bones into the vascular system? Is it that the source of exposure is not correctly identified and has been stopped? Or is it a combination of these answers? This one's slightly harder to test you. So we've got some answering B, some answering F. I think the correct answer is probably E, actually. So we know that the chelating agent, well, we don't think it actually appears as a confounder on assay, but we do know that there is remobilization of lead from the bones into the vascular system. So those answering B are correct. That is noted. The other possibility is that the source of exposure hasn't actually been identified, so they're still receiving lead from somewhere. So that may also be a reason that the blood lead concentration is going back up again after chelation. So it's probably either B or C in this instance. But I understand this is a very challenging thing to get your head around. It's quite a difficult one. And I suppose potentially you could expect some of the bound lead on an assay to actually appear. So it may be all three of them, but I would say B and C are most likely. I think that's all from me. I'm going to hand over to, before I hand over, is there any questions for me on lead poisoning before I hand over to my colleague, Nick? Nick has indicated you're most welcome to put questions in chat, and we will get around to them. I'll happily look at every question you have. I'll pass over to Nick now to continue with arsenic. Thank you very much.
Thank you very much, Talon, and good to see you all doing well in the quiz. I was struggling myself with that last question. Yeah, I had to read it a couple of times. I'm going to come on to arsenic now. I'm going to follow a similar format to Talon. He's obviously talked about some of the antidotes in a lot of detail, so it'll probably be slightly shorter, but I'm just going to do a little bit on what is arsenic, the species and sources, talk about how it behaves in the body, its mechanism of toxicity, again, talking about features of toxicity such as acute and chronic, and of course, very importantly, the clinical management. Okay, so first off, with regards to species, what is arsenic? It's known as the king of poisons. So it's been used for a long time. In ancient times, when people used its toxicity, it's been used, to deliberately poison people since I think the 1800s in some cases. But it's natural. It occurs in rock. That's why you see some of the problems in Zambia. Mining that rock has caused some issues and exposure to population. And, it also has industrial uses as well. Next slide. I'll just skip the slides here, Talon. That's all right. Just talking about the different species. There's the different forms of inorganic arsenic. And the main one to look out for is whether it's trivalent or pentavalent. That might be clinically interpreted with blood tests a little bit later on. But it's important to note that, trivalent arsenic is 60 times more toxic than pentavalent. So, if you've got a process in a factory or industry that's likely to create trivalent arsenic over pentavalent, probably mean occupational health needs to be more on the ball, and obviously you're more likely to get patients turning up at hospital after exposure to that. In slightly good news, organic arsenic is actually of quite low toxicity and is generally found in seafood and seaweed. That can pose a challenge from a testing perspective, but we'll come on to that a bit later. Okay, doke. So some of the sources of arsenic, one of the most common ones is contamination from the natural environment, getting into the drinking water supply, getting into groundwater, getting into drinking water boreholes, and in some cases, ending up in, in tap water if water treatment isn't sufficient. As already mentioned in the introduction, mining can cause release of arsenic into the environment. It can also be a contaminant in traditional remedies. I've got a slide on that shortly. Also used as a medicine. Arsenic trioxide can be used in some quite severe diseases, not routinely prescribed, but good to be aware that it is present there. And can result in toxicity if used correctly. It was historically used as pest control in agriculture. Worldwide, but these days it tends to be very limited as far as we're aware. We are aware of use in some countries by professionals for termite treatments. I know it's used in the US and a couple of other countries. If anybody is aware of arsenic being used in agriculture, do post in the chat because it'd be good for us to know. Next slide, please, Talon. Okay, and then just talking about herb, we're doing a little bit of searching around before this presentation. Come across this interesting paper, and it's about a herb called unsunko. Put your hands up if you've heard of unsunko before. Give us a little thumbs up or just to know. Just curious to know whether clinicians have come across it before, or maybe you've come across it. Of hearing of other people using it, and in this study. Basically, they took the authors went around a number of different stores in Zambia and tested what was in the unsunko herb. And you can see here, top left, obviously we're talking about arsenic, also relevant to Talon's presentation. Bottom right, you can see the lead's very high in one of the states there. And you can see that the arsenic concentration was seen as higher in Kitwe compared to other areas, possibly due to, with the mining that's going on there, and in Sunko being produced from the soil and minerals there. But just to say, don't just think about mining. There are other sources of arsenic as well. Thanks, Talon. Next slide. It's good to see all the thumbs up as well, that lots of you have come across it. So I'll just talk a little bit about the toxicokinetics. The major site of absorption is within the small intestine, but may also be absorbed through the skin or inhalation. If you're in an industry process where arsenic, pentavalent or trivalent is being released, it's more likely to be inhaled. But if it's in drinking water or even food, it will, more likely to be absorbed by the small intestine. It's distributed extensively in blood and accumulates in certain tissues. And there's a little diagram there, so showing how it's metabolized. You go from that pentavalent can be metabolized within the body, can be metabolized to trivalent, resulting in monomethyl arsenic acid, and then finally dimethyl arsenic acid before it's excreted. Point to note is it is mainly excreted in the urine, which will feed into what we recommend biomonitoring wise as well. So next slide. So just to talk a little bit about the mechanism of toxicity, exact mechanism is not actually completely understood. We do know that it burns sulfhydryl groups to inactive or dysregulate up to 200 enzymes in the body. And one of these enzymes, as an example, is pyruvate dehydrogenase, which is involved in oxidative phosphorylation, which is obviously a very key process in the body. And as most of you will know from a toxicology perspective, if you're dysregulating that amount of enzymes, that's going to cause lots of problems, from a clinical perspective. And that's probably why it's been hard to work out the exact mechanisms of action, because it has such an impact. But, it does affect cellular energy pathways and DNA synthesis and repair. And of course, as we'll mention shortly, arsenic is a carcinogen as well. Okay, next slide, Talon. All body systems are affected. We've got the GI symptoms such as nausea, vomiting, abdo pain, watery diarrhea, and excessive salivation. not very specific, but obviously things to look out for if people have been exposed to a large amount. You can also get psychosis, toxic cardiomyopathy, and seizures. So you can see all the main organ groups being affected there, then leading to renal failure, respiratory failure, pulmonary edema, peripheral neuropathy, or encephalopathy. So they're the acute effects. So somebody gets a very large dose of arsenic, that's probably more likely in like a industrial scenario if they're exposed to arsenic via a work process. But we'll come on to chronic symptoms now, which are probably is more common when people are exposed in the environment. And this slide here is showing that, again, all body systems affected. And in chronic poisoning, you get arsenic accumulate in the kidneys, heart and lungs, and more. And this is a good site to look out for on the right. If you've got somebody you suspect with arsenic poisoning, look out for Mees lines, which occur in the fingernails and toenails, which is quite, a specific symptom to look out for. I don't think you see that with any other common toxins, but do correct me if you're aware of other poisons that do that. And it can also cause dermatological changes, such as changing in skin color, hyperpigmentation, and also solar keratosis in the eyes. And again, increased risk of cardiovascular disease. So, if you think about arsenic, if there's a lot of exposure in a population, that's going to have effects on morbidity and mortality. Next slide, please, Talon. So these are the clinical management. A lot of these are symptomatic and supportive. We recommend, 12-lead ECG, full blood count, Usenis, LFT. Some of the more specific things you can do is, nerve conduction studies, and also we'll come on to this in a second, but whole blood and urine arsenic. Talon gives us an excellent summary of some of the antidotes there, but DMPS, unithiol, or DMSA are, effective antidotes. And this is the information from AfriTox, the database Dr. Kawa and co use in the Poison Center. And basically, that's the criteria for chelation therapy. Urinary arsenic levels over 50 micrograms per liter in symptomatic patients, or over 200 in asymptomatic patients. It's also another antidote, BAL, British anti-leucite, which there's some evidence to say it can be effective. But the problem with that is that there's some evidence to suggest that it binds arsenic, but then can still cross the blood-brain barrier. So, it might not be as effective against central nervous system effects. But apart from that, it's mostly symptomatic and supportive care. And so just to talk a little bit more about the chelation therapy, basically GMPS and DMSA increase urine arsenic excretion and decrease blood arsenic concentrations, which obviously will reduce toxicity in somebody with high exposures. We're saying that DMPS is available as parenteral and oral formulations, whereas DMSA is only available orally. That might matter if you were a hospital, depending on your capacity. If you're working in a rural hospital where it's less easy to give things parenterally, it might be worth having oral formulations available. And as I said, BAL can cross the blood-brain barrier after binding arsenic. Okay, and this slide is just, covering, it's a nice little diagram. We will be forwarding these slides afterwards, but, showing all the different ways that supportive care can help with arsenic. Things that haven't been mentioned already would be convulsions management, which I think is standard treatment, such as diazepam, IV fluids, and it does mention here as well red blood cell or platelet transfusion if there's a lot of toxicity to the hematopoietic system. And obviously your IV fluids will correct electrolyte disturbances as well. Also worth highlighting that if somebody's got renal failure, you can give them, you can give anyone with renal failure hemodialysis, obviously. In arsenic poisoning, the amount removed by hemodialysis is quite small, so it doesn't actually remove arsenic particularly well. But if somebody's going through renal failure, it may be worth considering it in that as you would anyway in renal failure. On the next slide, please, Talon. And yeah, so just to talk about blood samples, we've got a little survey after this presentation on blood test availability and antidotes. So we'll come on to that shortly. But yeah, urine is preferred over blood in most cases. It's better. It's a better way of basically, estimating someone's exposure and serious of toxicity. So urine is definitely better if your lab can take and analyze those symptoms. And, a one-off spot urine specimen will suffice. But if you're using chelation therapy, it's worth doing every 24-hour urine collection to see how effective chelation has been. As I mentioned, the seafoods earlier, the organic mercuries are actually non-toxic or of low toxicity, but they're found in seafood and seaweed. So just to be sure that if you are testing somebody for arsenic, you ask them about their diet and things. Be honest with, obviously with Zambia, obviously seafood and seaweed is less of an issue, but yeah, if it's something for clinicians to be aware of generally. Yeah, and also in some laboratories, they can do arsenic speciation and determine the type of arsenic, and that might help you estimate how severe someone's poisoning will get, depending on whether it's trivalent or pentavalent. Also worth saying, arsenic in hair and nails is generally not useful for clinical management. It might be useful to estimate exposure or previous exposure, but even though you can test it, it doesn't actually help you clinically manage a patient. Next slide, please. Okay, doke. And so as Talon's kindly put together this quick example for us here. So I want to get you all thinking again about this case study. So we've got a 29-year-old male, and we found out he's been drinking water from a ground well, and he's heard rumours, and he's concerned that he's been poisoned by arsenic. So he's been drinking it for 4 weeks. He's had some diarrhea and vomiting. He's got some white lines on his nails, numbness in his feet, and hyperpigmentation of his skin. Okay, doke. So if you have a patient who presents to you with these symptoms and history, which tests would be most useful for diagnosis? So there's 4 options there. I'll give you 15, 20 seconds to, answer A, B, C, or D in the chat, and we'll go from it. So we've got an A already. Any other? If you could, everyone who's online can post what they think. So we've got. Okay, doke. I think everyone's got that right because I agree with A. I hope that's right, Talon. Yes, it's right. So yeah, for diagnosis, blood and urine is most helpful. As we said, hair and nail sampling doesn't really help much with clinical management, so you really would be looking for blood or urine concentration. I would say that in the UK, some of the hair and nail sampling that gets done isn't always done by accredited laboratories as well, so we don't always, when we get the results, always trust them as well. But there is ways to do good hair and nail sampling. Second one, hopefully this is a straightforward one. Are these symptoms typical of arsenic poisoning based on what we've discussed so far? A, yes, or B, no. Far, we're all agreed that is toxidrome, the symptoms, especially those transverse white lines, does suggest arsenic poisoning. But always consider other sources, until other potential causes, until you get laboratory confirmation. And the next question. Okay, so you've had this patient arrive at the hospital. You've sent off the bloods, and what should you do in the meantime? Should you A, chelate him, B, reduce, look into ways of cessation of exposure, i.e. advise him to stop drinking water from that source, or C, encourage the patient to drink milk and lemon juice? Which ones of these do you think are the most important? Okay, good to see all the engagement even after an hour online, especially in the evening. We do really, we do really appreciate this interest at this time of the evening in Zambia. Yeah, so as you say, you've all got it right there. You want to look at cessation of exposure. if last thing you want him to be doing is drinking more contaminated water in the meantime. Not a role for the clinician really, but if this was a incident which affected a population, for instance, colleagues at Ministry of Health or ZMPHI might be looking at, potentially, recommending providing alternative water supplies such as bottled water or, even bowsers and things, water bowsers in some cases, but not for clinicians, but good to know anyway. Okay, a couple more questions on this one before we move on. Okay, so okay, so as a clinician, we've just found out that 2 other family members are also reportedly unwell. And what other action would you take? I think I've given some of these answers away, but so basically, this is again, I'll give you like 30 seconds to read this. So A, B, C, D, E, or F. Do you want to send everyone for clinical assessment? Do you need to inform public health? Do you need to collate everyone, or is there a combination of some of those? You see, we leave the harder ones until the end. Oh, somebody's answered L. Interesting. Okay, so this one's got a few different answers here. Do you want to let everybody know the right answer, Talon? A and B. Yes. So key point to mention here is encourage people to attend for assessments. It sounds like a lot of people have been exposed here, and obviously the family have, but until you get blood results back, I don't think you'd be recommending collation. I see a lot of you said F, which is, A, B, and C. So the main thing to do is get them in, assess them properly, treat them supportively, and again, send for a arsenic level and assess them further. And obviously, until they're at the hospital, you can't properly clinically assess them. So yeah, the correct answer is A and B. Hope that's okay. And do we have one more question, Talon, or is that it for arsenic? Okay, yeah, the final one is, which arsenic assay is most useful when establishing the need for chelation therapy? So if, when you're deciding on chelation therapy, would you go for A, a blood sample, B, a 24-hour urinary collection, C, a spot urine collection, or D, a hair or nail collection? And again, post your answers in the chat. All right, I'm just scrolling down a bit here, 2 seconds. Okay, so most people are saying B, C, and we got 1D. Do you want to let everybody know the correct answer, Talon? So it's a 24-hour urinary connection. I think if I interpret it correctly, when you're having to think about collation, it's good to have 24-hour urinary collection. If you're just trying to test whether somebody's got, been exposed to arsenic, a spot urine collection is useful. But when you're establishing the need for collation, it's best to get a 24-hour one. Anything to add to that, Talon? Have I missed anything there?
I've just added that a spot urine collection is perfectly viable if you haven't got a 24-hour collection. It can be quite difficult to get that 24-hour collection.
Yeah.
So spot urine collection is also very good to use. The main thing is the blood samples are less good than urine samples, and as we talked about, hair and nail collection is not very good at all. That's it.
Brilliant, thank you, Talon. I've had a problem with my internet connection. We'll try putting my camera back on now. Okay, doke. So going on to the next slide before, so just as a summary, okay, we've discussed arsenic having many sources: contaminated water, mining, industry, medicines, pesticides, lots of different sources. Don't always assume it's mining, even though it's quite often the case in Zambia. Water is obviously an issue as well. We've talked about the different types of arsenic species. And how it can affect all organ systems, and that, basically it's going to be collated with DMPS or DMSA if available. Okay, doke. But we've got a little survey for you now, but before we move on to the survey, does anybody have any questions on what I've just presented on arsenic, or, feel free to put your hand up or post in the chat, whatever's better, or we can leave questions till the end. Okay, doke. You're obviously happy with that. If you do have any questions on lead or arsenic, Talon and I will be, saying after Dr. Kawa's presentation. We do have another 45 minutes. I know it's a long session, so hopefully we'll finish a little bit early, but it's good to see all your engagement at this stage. Okay, so hopefully most of you have used Menti before. If you could either go onto Menti on your phone or your computer, www.menti.com, and put in the code there, 44918119. Alternatively, use your phone to take a photo of the screen there, a photo of the barcode there. Basically, we've got 3 questions. And first off, this is all anonymous. We're not, testing particular hospitals. We're just trying to get an idea of the level of availability of antidotes and blood tests, amongst those of you who have kindly dined in today. I would say that I'd only answer this survey if you're a clinician. If you're not a clinician, I know we have colleagues on from ZMPHI. If you're not currently, a clinician treating patients, there's no need to answer this survey because we're really looking for answers from clinician. And within the survey, there's questions around type of clinical facility you work at, and then questions about toxicological laboratory and antidote availability. Hopefully that is all working for you now. It will give you 2 or 3 minutes to answer those questions. Hopefully it'll be quite quick, but I'll be keeping an eye online on results as well, and might be able to have a chance to show the results at the end as well. So I'll just give you a couple of moments. Okay. I can see you are very engaged. We have 12 respondents already, but I know it might take some participants a bit longer to answer. So I'll give you a couple more minutes before passing you on to Dr. Kawa. Okay, I can see we have had 15 participants so far. Yes, we've got 15 participants so far. Just to say, you can continue answering this survey for the next couple of days. So in the interest of time, we'll probably pass on to Dr. Cohen now, unless somebody has any more questions or has any questions on the process, feel free to put your hand up. But it sounds like you're all using Menti well and have used it all before. Oh, now up to 19, actually.
May I suggest we proceed with the last part of the presentation as people continue to fill in
No problem at all.
Yes, please.
I agree totally, Dr. Banda. We'll move on now. Yeah, thanks. If you can move on to slides, Talon, and just want to pass on to Dr. Kawa, who's been a pleasure to work with over the past few years, and has been a real champion for our work with UKHSA and developing poison centres. Thank you, Dr. Kawa.
All right, thank you, Nick. So I think mine will be quite a short one since management is there are lots of similarities, and yeah. So basically, that's the outline. So next slide. Okay, so manganese sources, so like the other two presentations before, a lot of the source is occupational. You see that manganese is naturally occurring and makes up approximately 0.1% of the Earth's crust. That sounds like a small number, but it's actually quite a large surface availability. So used in industry, drive battery cells, alloys, fungicides, welding rods, to mention a few. Also an essential element in our metabolism for bone formation, in the immune function, and also in
Apologies for that. We are still trying to get hold of Dr. Kawa. I think his internet has become problematic at the moment. If there are any questions regarding the previous two presenters, they are more than welcome. We can look at them now as we hope for Dr. Kawa to rejoin the meeting.
Yes, Dr. Banda, if you would like, I'm sure Talon and I can cover these slides between us if Dr. Kawa isn't able to rejoin shortly. But be great if he could rejoin.
Yeah, I think you can take it up.
Okay, I'll do the next few slides on sources and a little bit and I'll pass on to Talon if he's happy with that on the features and clinical management. But yeah, as Dr. Cole was saying, manganese is a naturally occurring element found in the Earth's crust. Essential element in human metabolism, bone formation, and immune function. Also worth saying, it's essential nutrient, so it's also found in vitamin mineral combinations and also parenteral nutrition. So everybody needs manganese, but you can get in toxic quantities too. I think in some places in Africa, manganese has been found as a contaminant in street drugs, termed as bazooka or bazuko, which is sort of like a cocaine-based paste. Anybody has come across this in Zambia, please put your hand up or put a thumbs up. It'd be interesting to know. And also, as with arsenic, poisoning can occur from manganese contaminated drinking water, and again, common with a lot of the metals we're talking about, inhalation of manganese can result in toxicity as well, mostly from industrial things such as welding or smelting or mining. On the next slide. Okay. And yeah, just a couple of stories, which are relevant to manganese. You may recall a few years ago, I know Dr. Cole was heavily involved in testing people from this site, when 35 workers, the headline says evacuated, but I think the better summary is 35 workers were very ill following exposure to manganese as part of work. And you can see there some of the symptoms were very reported as quite severe for manganese poisoning. I remember discussing some of the symptoms with clinicians from the US, and they said, they hadn't seen, symptoms as bad as this, from manganese poisoning there in many years. And obviously, occupational incidents like this, dust and things are spread into people's homes and into the environment. They can also become a public health risk as well as an occupational health risk. Not to say there was evidence of that in this incident. On the next slide, please, Talon. Okie doke. So this is a little bit on manganese toxicity and pharmacokinetics. It can accumulate in the brain, where it basically crosses the blood-brain barrier and is cytotoxic to neuronal cells. Exact mechanism of toxicity is unknown, but it likely involves oxidative mitochondrial damage, particularly in the basal ganglia. It's no specific toxic dose available. However, we don't usually get acute toxicity from manganese, and tends to occur from chronic exposure. A little bit about how it's absorbed, and again, fine particles, especially those under 5 micrometers. Think about PM 0.5 and PM 2.5. Those small particles, they get down into your lungs really quite easily and absorbed into the bloodstream. And only 1 to 5% of ingested manganese is absorbed in adults. So ingestion is not absorbed quite as well as inhalation, but obviously you can be exposed to far greater quantities, in some cases via drinking water and food. If you get manganese on your skin, it's apparently limited absorption. So the main routes of exposure are inhalation and ingestion. The half-life is around 10 to 40 days in blood, so it's does stick around in the body for quite a while before it's excreted. But if it does cross the blood-brain barrier, it can persist in the brain for months, and that's where the major site of toxicity. So important to remember that. Next slide. Oh yeah, this interesting study, and we were having a look around the peer-reviewed. Dr. Kawa and I were looking around the peer-reviewed literature for what's there on manganese. I found an interesting paper here, which again was using human hair and nails, which isn't the best for clinical management, but a useful biomarker. And when we were reading around this paper, we noticed that in the Mugala community in the Zambia copper belt. We noticed in the paper this little table on the right with they only sampled 5 wells. So they didn't do much environmental sampling, but one of the wells was well above the WHO drinking water guideline of 0.4 milligrams per liter. It was 1.47. And just to say, the WHO recommend levels below 0.4 milligrams per liter, but there are some studies out there showing that exposures of 0.241 milligrams per liter in one review thought that if exposure happened over 3 years, i.e. chronic poisoning to a level of that amount, which isn't huge, could result in poor neurobehavioral tests in school. Probably worth highlighting that we've heard a lot about lead and its toxicity, and a lot of research has been done on lead because it's so widely spread around the world, especially in and also in the Western world, it presents a problem. But just because there's less data on it doesn't mean things aren't as toxic. So manganese isn't as much of a worldwide problem as lead, but we realize this is specific. It has been a particular problem in Zambia. So just to keep that in mind as a clinician, that there's probably less clinical reviews and data out there, but that doesn't mean that it's not having as many significant adverse effects. It just might be they're harder to detect in the population. Okay, next slide, Talon. Would you like to take over here, Talon? I can see Dr. Kawa is back on. Do you want to take over from here, Dr. Kawa, if your connection is okay?
Sure thing, Nick. So I don't know how far you went, but this particular presentation you were talking about, it was done by a lecturer in chemistry from the University of Zambia. And they were doing a survey of hair and nails. And they had quite interesting results. They found that manganese, cobalt, lead, cadmium, and zinc were above the interval values in participants in that study. So and you can imagine now these in the future you might find problems now related to this the same elements. So health effects, acute, you don't really find that so much. The reason being that absorption is quite in neonates, because absorption may be increased. Fortunately for neonates, exposure is going to be really from the mother, number one, or
Nick or Talon, you may just want to come through and maybe proceed to conclusion.
Thanks, Dr. Banda. Yeah, no problem at all. So as Dr. Kawa was highlighting, the sort of acute health effects are quite unlikely. Typically with manganese, we're expecting chronic toxicity to be the mainstay of toxicity. So typically you get a nervous or psychiatric stage initially, which is self-limiting. So this may include impaired memory and compulsive actions. So very much sort of neurological features or neuropsychiatric features. And then you get this progressive severe neurological signs that resemble Parkinsonism. And I think Nick touched on that some of the sort of the broad clinical spectrum effects from chronic manganese poisoning is called manganism, which is very sort of specific to manganese poisoning in chronic toxicity. So this then goes into speech and gait disorders, and then gross movements of limbs, trunks, and head. So chronic ingestions of low concentrations of manganese as well may give way to permanent brain injury, and recovery is quite rare once the advanced CNS syndrome develops. So although we don't see it very often, chronic manganese toxicity can be very devastating, and it's something to consider alongside the other heavy metals we talked about today. In terms of clinical management, and realistically, this is probably the last slide we've got on manganese before we wrap up. The mainstay, as with all heavy metals, is to remove from exposure. That's always the most critical aspect. Treatment is symptomatic and supportive. There isn't much evidence for chelation therapy with manganese toxicity, but one thing you can give is L-DOPA, so levodopa administration, which may control some of the extrapyramidal symptoms. So you're effectively managing them slightly like how you would manage Parkinsonism. So 100 milligrams 6 times daily, increasing gradually to the optimum dose of 8 grams, and children, as you can read there as well. So yeah, in terms of chelation, the heavy metal antidotes like disodium meditate, calcium disodium meditate, and BAL, the British anti-Lewisite, are regarded as quite ineffective against the CNS symptoms. So once you've got this frank onset of CNS toxicity, it's quite difficult to reverse, and really you're just focusing on supportive treatment with L-DOPA. Large doses of calcium salts by mouth may be indicated as oral manganese leads to increased fecal calcium loss and lowered serum calcium. So much like with lead, you may expect a knock-on effect with some of these other metals inside the body, like calcium. I think that was all from the manganese perspective. I've just included the Zambia Poison Information Center poster one more time as the concluding slide. But I'm sure myself and Nick and Dr. Kawa, if he's around, would be happy to take any questions from you all. Thank you very much.
Thank you so much for the presentations. We're grateful for this information that has been shared, very informative, especially even for our local context. There's a question in the chat box to say, which is the best laboratory test for suspected manganese poisoning?
Yeah, excellent question. I'm not sure. I would assume that the best test would probably be for a manganese serum concentration. Is probably your best bet. I suspect that it's unlikely to be readily available. Certainly in the UK, I can't think of where I would readily obtain a manganese poisoning, a manganese serum concentration, but I suspect it's going to be a serum concentration is what you'd be looking for.
All right, thank you.
Yeah. Just to add to what Talon said, when we were doing some research, we didn't see a lot of, like we have for other heavy metals like lead and arsenic, where you get a certain level in your blood or urine. There's an intervention level where you would give an antidote, and there's not that much evidence for it. But I think you're in a unique situation in Zambia where, you've had numerous incidents where, might be a good one for Dr. Kawa to answer when he's back online, if he does rejoin us, I think, to see if they have any capability for blood as well. But I do know that following the syringe incident, there were lots of raised manganese levels present. But I think what's needed is people to do clinical reviews, not in Zambia anyway, to look at all the evidence to see if there can be like intervention levels and with regards to how that might influence treatment and things. Hope that.
I've also just checked the guidance on both ToxBase and AfroTox, the two primary clinical toxicology databases that myself and Dr. Kawa uses in the ZPAC, and neither of them actually recommend sending for manganese serum concentrations. So in terms of identifying and diagnosis, I suspect it's probably more challenging than the other two, which we've got much more readily available serum and urine concentrations. So just thought I'd add on to that. I also see a question: which treatment has been used in Zambia for management of manganese poisoning, looking at the high numbers of cases? This is a really good question, and I feel like it may be best that our colleagues on the call may be better placed to respond to that question, or potentially Dr. Kawa if he's here. I would have assumed that the treatment would tend to be symptomatic and supportive and potentially using L-DOPA, but I'd be very keen to hear other perspectives.
Yes, Talon, it's mostly symptomatic and supportive. And I mean, chelation has been tried, but we know that from evidence and literature, the response is not that great.
Thanks, Dr. Kawa. That's much appreciated for your experience with that. There's also a question, is there any adverse effect on chronic lead poison patients who receive blood transfusion to correct severe anemia? I don't believe so. I think you'll be more than welcome to, manage anemia as you normally would in a lead poison patient. So I wouldn't expect there'd be any adverse effects from that. So I suspect you would manage the anemia as you would typically, and you would manage the lead separately, unless anyone has anything to add.
Thank you so much for those responses and the questions that have come through. Any more questions? Any hands? Any burning issues? Okay, there's something from Gift Zimba. Does Zambia have a good geographical map of such heavy metals? If yes, can we be availed? Dr. Kawa, would you be able to address this one?
I think this one would be one for the geological survey. Yeah, we can probably look that up for you. But yeah, it's a good question. I don't have an answer to it.
Yeah, just to add, we are aware of some. They're in. If you search in the literature, there are some good studies being done from geologists. Both there was a joint Czech and Zambia study, which we can dig out the link for and provide, which did do a lot of monitoring of soil and water concentrations in the copper belt to try and ascertain what the background levels were there. And I believe that included, many of the metals mentioned today. But we can dig out a link to the PubMed, to a couple of papers describing that and share them. That shouldn't be a problem.
There's more questions and suggestions coming in through the chat box. Mangani Sakala says, kindly share the links to the abstracts in the PowerPoint presentation. So I think we'll be able to share that via email at an appropriate time, as we have a mailing list for all the members of the Medical Association. There's a comment by Jones Chibuye to say we also need to do a public health risk mapping on such and similar chemicals of public health importance. That's a very good suggestion. Perhaps Dr. Kawa will give a comment to that. Then there's a question to say what are the recommended screening protocols for suspected occupational exposure to manganese on a large scale? Dr. Kawa, would you want to start?
Yeah, thank you very much. So, screening protocols. So, of course, serum is your best bet. If you want to do it cheaper, you could do urine screening as part of screening. So, there's some high sensitive, but maybe specificity is not very good for you. So urine on a very large scale. Then if you want to really be more specific, blood levels, serum.
Regarding the mapping for the general population at risk as a matter of public health concern for some of these heavy metals, there was a recommendation that perhaps we need to do a mapping for the same. So maybe that is something that can be considered on the long term upon advisement from the relevant bodies. And I think such discussions need to be had to form a basis as we go into the data that is available so that we can inform policymakers and see how best we can contribute to the data, the body of information in the country, in the region, and in the globe as a whole. So I think that will be my comment on that particular part. Any other matters of concern or any additions are welcome at this point. Yes, Isaac Banda.
Thank you so much. Excellent presentations. I just wish to find out on manganese poisoning. When you compare the processing of manganese and the actual mining, where would one likely get poisoning? Is it from the actual the processing or the mining part? I might have missed that if it was discussed earlier.
Thank you, Dr. Banda. That's a very good question. So you will get exposure in both. Remember, with mining, it's mostly inhalation, where there's blasting your soil into the air. So that's why the emphasis on PPE is very, very key to avoid that exposure. So in other processes and industries, you can get similar exposure. There now you're using it as like in industries you use it as an for alloys, for wood processing. So there now you're using the actual manganese for processing. So in such cases, similar safety measures of PPE highly recommended. So but I would probably say mining, because of how it's in the natural occurring state and you're blowing things around, and the exposure is much more than when you're in a well-confined processing industry.
Thank you, Dr. Kawa, for that response. Any other burning issues as we draw to a conclusion of the webinar? Okay, we do not seem to have any hands, and I don't see any comments coming through in the chat box. So at this point, I'll just... Oh, Jones. Jones has a hand up. So Sir Jones Chibuye, please go ahead. Jones Chibuye, you may go ahead.
Am I audible, please?
Yes, you are audible now.
Okay, thank you. I just wanted to also add up to Dr. Kawa's response that it can also be gotten through the processing process. Like there's quite a much higher chances of exposure through processing, because the ore, when it's being mined, when the ore is being mined, mostly like having some lesser concentrations of manganese. And what we do with the processing process is to try and get much of the impurities out of the ore and then have that ore into the metal. So during the processing, that's where there are quite a lot of dust, which gets now like higher concentrations of the manganese itself. And if the process has got so many leaks, then it will expose the people much more. That's on the occupational side. Just to add up that as another addition on the sources of exposure. Thanks.
Thank you so much for that contribution. With that said, I think we can safely come to the conclusion of this evening's webinar. Would like to thank the presenters for their availability, Talon, Nick, Dr. Kawa. Very, very important discussion, and thank you for highlighting such matters of importance. Just to bring it a little bit home and for people to be aware, as there was a tailings dam failure on the copper belt somewhere in Kalulushi, and these particular heavy metals were released into the environment. So an environmental impact assessment report has been released, and just to read verbatim from one of the introductory remarks is that trace and heavy metals such as lead, manganese, arsenic were measured in soils and plant tissues to assess the crop uptake of the trace and heavy metals. So it was noted that elevated metals in the soils in high impact areas with potential for crop uptake if farming resumed without remediation was going to be there. So these are not far-fetched problems that we are facing or imaginary problems that would or would not happen. These are actual real problems that are within our environment. So much as the assessment was centered on the environment, on the water bodies, and on aqua life, and partly livestock, none has been done so far on humans. So for those of us that are working within these areas and with these localities, these are things we need to start thinking about and start checking in our patients so that we'll be able to generate data and inform the relevant authorities in the near future, because we may start seeing some of the effects of these accidents in some years to come. And of importance to me was the fact that whenever we have suspected poisoning from heavy metals, it may not necessarily be mining. So we need to start thinking of other sources, as were highlighted, such as batteries, the very things that we use on a day-to-day basis, as maybe sources as well. So thank you so much to all our presenters, and we are very grateful as Zambia Medical Association. We look forward to the presentation being shared and for them to be distributed to the membership for reference. At this point, I'll invite the Vice President of the Zambia Medical Association to give his concluding remarks as we close. Dr. Bright Mackenzie.
Thank you, Dr. Banda. I think you've already done the good job and the closing remarks. Mine is just to add on the appreciation on our presenters. I think it's very important. We shouldn't take it for granted. These are very busy people with busy schedules. We thank them for sacrificing their time to teach us what we needed to know. So thank you so much, our presenters, and also thank you to our members for finding time out of their busy also to listen and learn. Thank you so much, Dr. Banda. Back to you.
Thank you, dear listeners, colleagues, and senior colleagues. I think we call it an evening. Until next time, bye-bye.